on histologic versus pH results for laryngopharyngeal reflux.
Thank you. Thanks everybody for coming. Thanks Dr. Thompson and Dr. Franco for moderating, and the Academy for letting us present our data today. We wanted to start by showing our disclosure and acknowledging those who helped with our research collection. No one can go it alone, as you know. The objective of this study was to really compare what we were seeing in the pediatric patient in regards to histologic findings for reflux to what was a relatively new mechanism, and that was the probe that was a nasopharyngeal reflux probe, and we used LPR as our diagnostic nomenclature, although there are many synonyms, as you'll see. And the reason we did this is that for many years we had been using histology to diagnose reflux because our GI colleagues were still using single lumen probes, and their diagnostic criteria for a positive result was based on pure esophageal data and not on pharyngeal data. So there was a little bit of a disconnect there. We did this as a retrospective review. And basically in June of 2009, we started using the pH probe that was manufactured by Restech, and we compared that with our post-cricoid biopsies, which we had been doing for several years. And this was based on a study by McMurray and those at Cincinnati where they compared histologic findings for subglottic stenosis and complications of LPR. And of course, the device, if you've never seen it, is a nasopharyngeal device. It's a very narrow probe. It has a nice teardrop-shaped tip, which allows it to sit off the mucosa. It also analyzes both aerosolized and liquid droplets so that it doesn't dry out. If it does dry out, then what happens is it eliminates that data automatically. It stays at the level of the soft palate so the patient doesn't feel it. That's particularly important for pediatric patients who don't tolerate anything that causes dysphagia, as you would probably know. And then in the back is a little LED light that allows us to see where the location is, but also allows the patient to go home, turn off the bathroom light, and look at the blinking red light in the back of their throat. This is a private practice setting in a tertiary children's hospital. And just by way of introduction, as I mentioned before, there's several synonyms. Probably LPR and ER are the most commonly used, but also supraesophageal and pharyngeal reflux are also used. For me, personally, I think the clarity came in the 2002 position paper by the Academy, which really clearly defined, and I'm preaching to the choir obviously, that LPR is a different pathophysiology than gastroesophageal reflux. A different patient population with different symptoms, namely daytime refluxers, throat clearing, cough, a lot of hoarseness, globus sensation, maybe nasal obstruction as opposed to GERD. And then following this, Wiener, who's a gastroenterologist in private practice, published in the Journal of Voice, pairing the probe with a triple lumen probe that was both esophageal monitoring and pharyngeal monitoring, and quite convincingly showed that there was reflux that started in the esophagus that continued up into the nasopharynx or pharyngeal probe. The important thing was that the pH was not below 4 for most of the pathologic reflux in the pharynx, but more along 5.6. And then adult normative data values for this probe were established in 2009 by two sort of simultaneous papers. And these papers used different methods. The first one using a modified version of the probe that sat in the upper esophageal sphincter, upper esophagus level, and the other one nasopharyngeal, to eliminate any confusion between the two types of probes and the types of monitors, and showed that there are definitely reflux episodes that come into the pharynx and nasopharynx that are associated with a esophageal reflux. And usually a drop of about 10% would yield a positive reflux. So our patients, there were 63 total patients, as we said before, and as you can see here, as you can see here, the number is 63, and the number with complete data sets was 50, and this 11, 3, and 1 don't add up to 13, as you notice. That's because 2 of these patients with no biopsy ended up in the group with a pulled probe. And that was sort of a learning curve for us, the pulled probe. A lot of those were young kids in the recovery room who were just a little bit out of it yet. And so these 63 patients, because they were selected as having suspected reflux, these were the symptoms we were looking for. Very common symptoms for those of you who deal with this entity. The cough is inclusive of throat clearing as well in this finding. And these were the symptoms of the patients with complete data sets. And as you can see, most of them are, as you would imagine, nasal congestion, cough, postnasal drip, earache. And these are a lot of the symptoms, obviously, that children have with upper respiratory infections, which are quite common in that age group, which makes it even more challenging. These probes were inserted while the kids were asleep, usually for other reasons, and these are the other reasons. Now, 11 of those 50 with complete data sets only were going to sleep to get a biopsy, so they had the probe inserted at that time, and then they wore it overnight, and we took it out in the office the next day. There was a certain number of patients who had surgery prior to the pH probe, and for a lot of us, we see this clinically as well, and that is patients are treated and both medically and surgically for sinus and other disease entities which turn out to be reflux in the end, which can be kind of frustrating. The associated comorbidities here, which is very common in the pediatric age group. And then this is kind of a busy slide. It gives you the information in 3 different formats, both as a graph, a table, and this written statement below. But basically, when we looked at our data, we saw that about 72% of them had a positive probe and a negative biopsy, and about 4 or 8% had a positive probe with a positive biopsy, and then the other was negative. Our results, male and female, were a little disparate, but we saw that 80% in both groups were positive. And of the 50 patients with data sets, 40 were positive for reflux, and 38 of these were treated with a proton pump inhibitor and 2 with dual therapy. And then, most surprising of all, 17 of the 40 were lost to follow-up, which is a huge number. And I think this was surprising to us because many of the kids had tubes and had scheduled follow-up, but they just didn't follow through with it. 23 that were followed up had an average, and then 18 patients resolved their symptoms, so a good 80%. And this is a normal, and I'll just flash through these very quickly. And just the limitations of these, obviously, are it's retrospective, a poor follow-ups, and then we don't know if some of the surgery also had solved some of their symptoms. So there's our conclusions. 80% had symptom relief. So thank you very much.